A year and a half after that, she had to give a deposition. And what they did to her was they handed her a simple Chloroprep, Duraprep, whatever they had, and they said, hey, here, tell me, what's the percentage of alcohol in this? 70%. You got it all highlighted for her. What's the dry time? It's a dry time. 3 minutes. How about if it's in hair? Have you ever waited an hour? So, oh, that's the correct answer. So here's what so the lawyer just turns and looks at her and said, so obviously you didn't wait the allotted 3 minutes, and this is why my client burned. What do you say to that, right? So this was a particular case where it was pooling of, it was an OB case. It pooled, all the prep solution pooled down in her buttocks and her leg. Had no idea what was going on, and that was there. Dad standing at the head with the woman and goes, you guys smell something burning? And they're thinking just normal cordery smell, right? Well, guess what? She ended up with second-degree burns all on her buttocks and leg. So it happens, and it happens more than you think. And what I'm going to take you guys through today is just talking about what your role is in a fire. We're going to certainly talk about prevention. We're going to talk about suppression, and then evacuation. You guys do open heart here. Think about taking that patient with a heart-lung bypass machine and having to come out of that OR. It's not an easy task. I just worked with a hospital a few weeks ago that was new to start doing open heart. And we worked with the perfusionist, and it was probably 5 attempts before we got out of it. What I did was I put one of the perfusions on the OR table, and he held on to all the tubing. And I said, if it moves, let us know. We moved that thing 5 times before we got out the door, before he would say, move, move. So what we actually ended up doing to have the best result was to raise the table up, put the machine behind, and he held all the tubing up over the shoulder, and out we went. And it actually worked. But it's not an easy thing, obviously, right? So I want to go through your roles, because you guys all have different roles within the OR and coming out of there. And then the last thing we'll talk about is understanding your building. Then what we'll do is quickly get into an OR. I want to do a quick fire drill with you guys. You have to do it annually, so let's do that. And then I'll show you a couple quick fire suppression things in there as well. All right, so what are the associations, organizations? Everybody's talking about this. Joint Commission just released something, it was last fall, they talked about, it was a centennial alert, they call them, and they were talking about more fires again because there has been an uptick in them. There we go. All right, so the biggest thing when we talk about that are risk assessments. You guys use Epic?
Yeah.
So this looks familiar to you, right? So as we talk about this and going through these risk assessments, should you end up with a high risk, is there a discussion that takes place between anesthesia, surgeon, about decrease of oxygen? Good. I say, I do this across the country, and I get looks like I have 3 heads when I ask this question sometimes. So it absolutely is imperative that, because so much of because we'll talk about the different types of fires that we see, high oxygen rich environments are really what's important with that. So I'm glad you're doing that. If anything bad should happen, it's all about the documentation. This is the first thing we're looking at. What was your risk assessment? How did this fire how could we have avoided this fire? And all the associations and when you talk about, you look and do any kind of research, and it all talks about surgical fires are avoidable. And they truly are, right? So as we look at this, obviously what were the important questions to ask? Are we above the xiphoid? Are we using any laser, fiber optic, any of that? What's our ignition source? So, back for you guys that have been doing this a long time, you may remember that, defibrillators, we actually had to use paddles and gel them up and shock people, right? Now we have the nice patches, but I can tell you, I'm still a licensed paramedic, but I've been doing this for well over 30 years. I can absolutely tell you, shocking people, if you didn't press in hard enough, you would get arcs all the time. And that now, if I had a prep solution there, we used to have an issue with nitro. They'd have nitro paste on, and you didn't see it or know it, and you could at times hit them with that. So, we've come a long way since then. But anyway, your biggest thing is going to be 2 things to avoid these fires. Alcohol-based, your prep solutions, again, 70%. That's a lot. And the thing with these fires, you don't see them. They burn very, very hot blue, and you just don't see them, and that's why I asked if we could turn the lights off in here. I use a lot of times just regular old hand sanitizer, 70% alcohol. I'll light that on my burn pad, and you will not see it. When you turn the lights off, you'll see this big ball of blue. So that's the issue that you're going to have. It's all going to be about smell. I'm assuming you're using the smoke evacuators in your OR, right? So now, when you smell tissue burning in your above, that should key you up big time. We have seen that more and more, which over the last 5 to 6, 7 years where we're using them, and you're seeing less and less, obviously, smoke in there. So we should be certainly talking of, if you have a fire, what are we doing? You're following your RACE procedures, right? So it's rescue. Obviously, does it apply in the OR setting? Well, we should be removing your patient. Hopefully, it's a fire on them, and I'll show you in a second how you put them out, or in the cavity. Or more importantly, what takes people out of an OR is, and we've seen this of recent, have been equipment failures. So we just had in New York City I don't want to say Pyxis, but it was a medication distribution. I don't know if it was on sale, whatever one it was, but it was in their OR and the thing caught on fire. They also had one in their NICU about a month before that, and that filled that whole NICU right up with smoke. And the same thing in this OR. They were able to unplug it, but the whole unit was smoking from the back, and they had to get out of there. And don't think it's just fire that could force you out. In Boston, 6 years ago now, big place, 28 ORs doing this big horseshoe. Started their cases, they were down in the first 3 ORs, and they had raw sewage pouring out of the ceiling. Yeah, so they had to move pretty quick and get out of there, right? So those are things that we got to think about of how we would come out. So what do we do? If you have a fire in there, the biggest thing is to get your alarm pulled, because then your building starts to work for you. And what do I mean by that? Your HVAC shuts down, so it doesn't pull smoke from, say, this room into the hallway. If the hallway's full of smoke, it doesn't pull it in here. Same thing with your ORs, right? We want to keep the smoke out of there. Then what do we need? So once that alarm's pulled, we should be making some calls here. So the first thing is going to be if you're in there daytime, you call the control desk. Are those numbers accurate? So it was in your procedures. I just wanted to make sure. 5005 to get the control desk? Yeah. All right, yes. Good. We call them. You answer the phone. You should be thinking, okay, the next thing I need to do is pull that fire alarm, okay? Then, and after hours, you're just going to go right directly to your hospital emergency number. The biggest thing with RACE and containing is really the containment. We have had multiple fires in different healthcare settings this year. In Massachusetts, there was just one less than a month ago. It was an assisted living facility. 9 residents died, 30 transported out, and the 27 that survived all said, I stayed behind my door until the fire department came and got me. And those 20-minute rated doors are the same thing you had here. You have fire rated doors, keeps the smoke out, keeps you safe. If you are ever in a smoke condition, get behind a door and you're going to be fine, because they're all fire rated doors. And your other safe haven for you guys, as we're up here on the second floor, are stairwells. They're at least 2-hour rated stairwells. Again, those doors are always going to keep you safe. So the containment, and then we get to as far as evacuation. You really should not have to come out of that OR unless you have an environmental issue of smoke filling the room on you. But again, most of this is you're not leaving. It's just we're putting the fire out in the room. And we'll get through more in depth in that in just a second.
Excuse me 1 second. There's chairs here, people, if you want to come and sit. Sorry.
That's fine. So what happens if we have a fire? It's absolutely saline is your water. It's your best friend here. So if we talk about a fire in the cavity, it is saline. If you have a fire on the patient, you can use just a regular towel. And what you're doing is you're just taking this thing and you're literally, if you're going to come right across them. So if I'm taking this, I'm going to borrow you for a second. You're going to come right across the shoulder and put the thing down and sweep, right? What are we doing? We're pulling all that oxygen out. And that is the easiest way to put it if somebody on them. Drape fires, and we'll get a little more detailed in this in a second, but drape fires, get the drape to the floor, saline. Can you use an extinguisher? Sure, right? There's different types that we have here. And we'll go through that in just a second. So all of that, and I'm going to say this now, I don't care how big your fire is or was, we should be pulling the fire alarm. And the reason being let's say it's a quick fire, you have flame, you have a good amount of smoke, pull the alarm. Because your building, as I said, is gonna start working, but in your fire department, I'll talk to you at the very end, when they come here, they are not rushing through your OR. There's a lot of places firemen don't like, and ORs are one of them, and MRI is the other, right? They just don't, we have too much gear to get anywhere near a magnetic, so that's why they don't like them. But as we talk about this, again, remove the extinguished materials, remove the drapes, look for additional flame. If you have a fire on a patient, you have to start looking underneath anywhere where this could have pooled. And then obviously treating the patient. So, drape fires, common. We've seen, I should say, not as common as they used to be. Has anybody ever seen a burn hole in a drape? Yeah, I call them bullet holes, and you got lucky. Here's the thing, we've seen it decrease more when we've gone from exclusively foot pedals for your cautery to the handhelds. There's still both that are out there being used, but a lot of times what would happen is if surgeon wouldn't use the holster and they're standing on this thing and don't realize they're standing on it and they put a burn in it. You get a burn hole in it. It's not that bad unless you have pooling of oxygen underneath. So I had this anesthesiologist tell me years ago, and she, as a matter of fact, she just retired, and when she was going to school, they had a fire underneath the drape, pretty significant burns to the patient. And from that day forward, when they were talking about this, what they have done has taken the 50 cc syringe, pulled the plunger out, hooked a suction tubing to it, and just connected it to the suction. So what's that doing? Constantly pulling out the oxygen and doesn't let anything pool up underneath. I'm like, that was kind of brilliant for what's it cost for a suction tubing and a 50 cc syringe, right? But that's her standard of practice, and it was her whole career because of that. So, so certainly, again, the drape fires, we can use that towel to sweep, saline, and then just, if you are going to take the drape and you throw it to the floor and use saline, or just be careful, because what happens is that floor becomes like ice, it's like an ice skating ring for you, right? Especially if you're you're not in sneaks, you're in your Crocs, you really get slippery. We had a nurse actually in a case where she came, everybody's moving quick, and she hit that saline and went flying. So that's why I bring it up. All right. So the next thing we have is going through is, what about your roles? And what are you guys doing? And there's different roles for what people are going to do. So as we go through this, circulator is, when we talk about prevention, what are they doing? So it's ensuring that safe surgical environment. So what does that mean to you? Well, did we wait our allotted 3 minutes? Do we have a clear access to the fire extinguisher if we need to? Did we all have discussions on what we're going to do if there is a fire? That is really probably the biggest thing about it. It's all about this when you have to respond is, did we have communication? Do we know what each of us are going to be doing? And then again, making sure these extinguishers aren't blocked. I have been in so many ORs where you can't even find them. They're buried up against the wall, and if you need it, it's something you need kind of quickly, right? So we don't want to make sure we do that. We want to make sure that they also have that role that they're controlling the heat sources by making sure your safety processes are there, that they're managing the fuels. And what do I mean by that? Again, it's that dry time. And then making sure team members are all talking about reducing oxygen in rich atmospheres. Those are your two biggest things right there, right? It's your prep solutions and in your high oxygen enriched environment. You eliminate those and work on decreasing them, you'll have it, hopefully you're mitigated well enough. All right, we have a fire. What are they doing then? Well, certainly they want to go and assess the situation, notify the team, and then what are we yelling if there's a fire in your OR? You have a fire, you see a patient catching on fire, right? They just caught on fire. What are we yelling?
Help.
Help? How about anything else?
Fire.
Fire.
Yeah, and then what it should be also is fire, turn off the gases. You should decrease your gases immediately upon a fire. If you have that oxygen-rich environment, we want to decrease that oxygen. Certainly, if there's an airway fire, we'll get more into that in a second. We've got to turn off the gases before we extubate them. All right. So, and then we want to make sure we get the fire alarm activated. That is such a big thing too, right? Because again, it gets your building working for you. Internally, you're going to get help. Externally, you're going to get help, and it all starts with that fire alarm. Can't stress that one enough. When this, as far as evacuation, so what do we? They're going to be the ones to notify the control desk, help anesthesia, getting disconnecting monitoring, getting your making sure they're aware of how to raise the table and get the table up, and then make sure the room is doors closed after everybody leaves, and then every person here is going to have I want touching that table in this team. I want a person on each corner of that table when you're moving it, and anesthesia shouldn't be driving. They should be doing nothing more than bagging. Like I said, I've been a paramedic a long time. You guys are not used to moving down the hall, taking a left, taking a right. And if the table moves quick on you, you can extubate them very, very easy. I've had people where, we've been in a house cardiac arrest kind of thing, and they all of a sudden, the adrenaline's pumping with everybody, they move, and I'm standing there with a bag and an ET tube, and their patient's down the hall. It's just, you gotta be careful with that. And any kind of movement, obviously you can displace the tube pretty easy. So we get into the scrub tack and what are their prevention. So as we sit there and we talk about that, right? So we gotta make sure that, and I do this because 3 minutes can seem like a lifetime when you've got a surgeon yelling at you, let's go, let's go, let's go, right? We know that, you've all been there. But everybody seems, this little saying we have, when people are waiting, they're bad judges of time. Every half minute seems like 5. And I think you can all attest to, you've been in a situation at some point where it seems like it's forever. So just know that, right? So making sure all the prep solutions dry. I was at a facility not long ago when they had actually, because they had an issue, but the chucks they use actually has tape on it. And they tape it to the patient from under the arm all the way down and all the way to the buttocks. And that way when they press, nothing can pool underneath. And then they pull that chuck right out of there afterwards. It wasn't a bad technique to do because it kept them from actually letting any prep solution get down under there. So it actually works. So we went through 1 minute here, right? Long time. So as we go, this is the demonstration I wanted to show you here, but since we can't turn off the lights, but you get the sense. Whoops. Oh, actually, hang on. I gotta hit the plate. So think about it, in your OR center, you've got lights everywhere, right? When you look at this is actually prep burning, now you turn off the lights and that's what you got. You barely see it there, right? It is all gonna be smell. That is how you're gonna figure out that you've got this fire going on. And this is pretty scary stuff when you look at this, right? Because you don't see it. So how do we prevent a lot of this is in the cavity fires, it's all about not having dry sponges. We had a case that happened last February or March this past year, doing a case in the chest, nicked the lung. Nobody knew they nicked the lung, so the whole cavity's filling up with oxygen. They went in there, had a dry sponge. As soon as they hit the cautery, the thing caught on fire, pretty significant burns. They got saline, put the thing out pretty quickly. But listen, this happens, right? It happens, and this is where you just got to be careful there. So don't have dry sponges there was the big takeaway there. And that particular one, had this fire, never notified DPH, never notified the fire marshal. Right. Next day in the safety huddle, they're like, hey, what did DPH have to say? They're like, what are you talking about? So they never called anybody, never had anybody in there. So they need to go and making sure that happens, right? So again, gauze sponge, again, having them moist, especially around oxygen enriched areas. Drapes, as I said, yes, they can burn. Definitely can burn if you have a pooling of oxygen underneath. Hair. How many, what's a good way to mitigate that? You're not going to wait an hour, so what are we going to do? Use Betadine prep. That works. I had a good friend of mine was fishing last August. Actually, it's been almost a year now. So he's on his boat doing this rock thing, right? He goes and he casts, and the lure catches his ear and ripped half his ear off. So he needed surgery, a little cosmetic to fix the thing up. So he wakes up and when he's in anesthesia, he says to his wife, "What is all this?" And it was all goop. And what they did was just use the water-soluble gel. So, and he has a beard like yours, this big beard hair, right? And what they did was they just water-soluble gel his whole head. But I was like, good, I'm glad to hear they did that. Because otherwise they would have shaved your head and beard, and you probably wouldn't have liked that, right? You worked way too long to have that, right? So, yeah. So again, whatever, betadine works good, a soluble gel, whatever you can do to make sure you get that hair where you can get some sort of surface, and something to mitigate that is the key. All right, scrub tech, what are they doing upon the evacuation? Well, certainly, assist the surgeon in stabilizing, prepping the patient, packing the wounds, helping them pack the wound with sponges. I don't know, it depends where you are in the case, right? Are you gonna, if you just started, wherever you are, at minimum, we're just gonna cover and then go. And try, and there'll be a few more things there that when we talk about this for the surgeon. But, the other thing you're gonna need to think about is what needs to come with you. And that, you think about all your equipment out there and all your instruments. I guess the question's gonna be, if you have a sprinkler activation and you've got all this nasty water flowing around, you're not taking anything, right? But what are you gonna take with you in going to another OR? So that's gonna be the discussion you guys need to have and figure out what's going. So not only do you need to get the patient and all that equipment for the most part is gonna have to go with them too. And that's why I like to do these run-throughs in an OR, because you'll see it can be taxing, right? And again, you'll see assistant moving that OR table. So each one of them is on a corner, each person's on a corner of the table when you're moving it. All right, anesthesia. Where are my anesthesia folks? All right, we got a few of you. Excellent, good. So obviously, any of your oxygen-rich environments, we've seen this of recent as well. We just had a recent case where they were removing a lesion, just had a nasal trumpet in, non-rebreather on, didn't cinch it all the way down, oxygen flowing all over the place. As soon as they hit the cautery, the O2, the fire went right up into the mask. So now, again, why any fire in your OR should be fire, turn off the gases. They rip the mask off, throw it to the floor. But nobody turned the gases off. So they put the fire out, they're doing all that. One of the nurses looked over and saw the fire going up the tubing. Right? So it's, again, fire, turn off the gas is extremely important. So when we look at any excess O2 from the mask or cannula, it can definitely saturate hair, drapes, you're using pillows that much, but you definitely have things where you've got, covering the patient, or under, the foam piece there where you have the head. This is definitely where we're seeing your higher risks are what? Above the xiphoid, but definitely head, neck, and upper chest is no doubt where you're certainly at a higher risk. Plastic, do you guys do a lot of plastic work, surgery work? You talk to any of those surgeons, but when they were training, going through this, they have at least seen one or heard one, because there's so much above the xiphoid. And where I was just in New York City at one of the hospitals there, and it was pretty much Manhattan, eye, ear, nose, and throat. And they're above the xiphoid all the time. And this is like definitely real world to them, because they're just at a much higher risk. So what can we do with this? Anything we can do with keeping oxygen from building up underneath the drapes is that suction I was talking about, or just taking medical grade air and blow it around the area to dissipate. Whatever you can do to do that. We look at, if we have a case and we're up in the face, we want to decrease that oxygen and then go in with the cautery. So if you guys are doing that, what do we need to wait? How long should we be waiting before that turning the gases down, before the surgeon goes in there? Really a good minute, all right? That's really what you should be doing is 60 seconds. Is that common practice? I don't know, but and if you've got an area where you got a lot of oxygen blowing around, and before they get in here with that cautery, we should have that communication of O2 is down or it's off or wherever you're at. I mean, obviously we got to keep the patient stable, but then they can go in there with that cautery, and that is really how you're going to. And that is in literature all over the place. So you just need to be careful with that. All right, airway fires, absolute worst, horrible injuries, horrible outcomes. We don't see as many as we used to. They've come down. It's difficult to get statistics on this because we only have 28 states are mandated to report. And most hospitals that don't really want to tell you that they had a patient have an airway fire, right? So it's hard to get information. But I can tell you, we just had one in New York City within the last 6 weeks, and it was a PD case. They had a pretty significant airway fire with it. And what it was is, so if you're at that high risk, some things we can do to mitigate that. Use tinted saline in your ET tube instead of the air. So that way, if you do hit the cuff, you can see saline, there's blue saline floating around. There is a great guy up in New York City that we've talked with him many times. He's an anesthesiologist up there, and he actually put out a video of when he's training his new residents coming in, and they have a mannequin, and they actually built this thing so smoke is coming out of the mouth, and like, all right, react. What are you doing, right? So it's actually, he does a really good job with it, but we need to be thinking about what are you going to do. And I'll get into that in just a second. But if you were in there and we could potentially have an oxygen buildup there, scavenging with deep suctioning, wet sponges in the back of the throat are other ways to mitigate this. But I think if you do have a fire, you see smoke, what are you doing? We're immediately turning off the gases. I would then take saline and shoot saline down the tube and then extubate them. And you're gonna don't pull that tube hard, because you can see this. If you don't turn off the gases, you can see on this where you have a torch at the end. Secondary to that, if you do have a fire there, that plastic is all melted. We have seen cases where they've extubated them quick and left half the tube in them. So now what are you doing, right? So pull the thing out of there at a nice even pace. That's why I want you to saline first, then re-intubate. Do you guys have assisted devices, cameras in every OR? Yeah. You're gonna need them, because I'm telling you that upper airway swells up so quick. Like I said, I've been a medic. I have pulled, early in my career, I've cranked 8 people. 6 out of those 8 were pulling them out of fires to where you can't even bag them because their upper airway has swelled so much. So you just you have to very quickly get them re-intubated. Also, don't put high flow oxygen on. Start out at room air and bag them, because if you didn't get all the fire out, the last thing you want to do is have 100% oxygen and you're blowing into their lungs, right? Into the trach. So that is what you need to be careful of. So you get them extubated, make sure the fire is out, use some more saline if you need to, and then you're really gonna have to then make a decision, what are we doing here? Most of these cases are stopped because they need to get bronch. You're gonna just that's why they have such horrible outcomes. You really do. But your biggest thing is gonna be, again, get that fire out. Just be careful on your extubating them and then re-intubating them. And I would put money on you're gonna need some sort of assisted device to do it. All right. You'll see in this why it's so important. This is what starts happening, right? When you have that, you're seeing smoke first all in the mouth. All in your oral cavity is where you're going to start seeing it. Then this thing just gets to be a flame. So obviously scary stuff here. And again, you see what that tube looks like, right? If you pull that tube out hard, you just left it in there. So that is why we want you to just be careful pulling that tube out. When we talk about, so what are you guys doing during evacuations? You're pulling out of that OR. I need you guys to be first, certainly, disconnect everything. Shut down the medical gases. Make sure you take meds with you to keep the patient sedated. We just had that happen in this case up in New York. Everybody ran out of there and they forgot meds. So we got to keep them sedated. Take what you need with you. You can move them for the most part. You're just going from one OR to the other, and I'll show you again where you're going. But if you got to get out of there, you can leave them on room air. If not, somebody can grab a tank with the intake if they're that critical. But and then you guys have the last say. When you're heading out of that room, we want to shut off the medical gases. So we want to shut that down. You guys have the last say to that. It's how it's written in your procedures. When we get in the OR, I'll show you how to do that. Basically, you're just pulling off, there's a ring on there, you pull that ring, and if you shut one, you shut them all off. And the reason why, it's nice for you guys, because every OR has its own set of gases. When you get into PACU, you might have, it does half the unit, right? So we gotta know what we're shutting down there. So when we talk about that, going out, it doesn't need to be you. You can say, hey, I need you to turn off the gases, all right? And I gotta tell you, it doesn't happen, really where it's important and we want those gases shut down is if we have extension, which is we have fire that's up in the walls or up in the ceiling. The fire department has this pole with a big hook on it. And before they start ripping ceilings down, walls down, the last thing they want to do is hook into an O2 line or a nitrous line, right? To where now we're fueling that fire. Is it going to blow? No, but it certainly will. It can certainly fuel that fire. So that's the last thing you guys are doing as you get out of there. All right, surgeons. We have any surgeons? I didn't think so. Very rare that it happens. Only unless something really bad happened and they make them all come there. But again, listen, their roles. So this is where I need you guys to know their roles so you can tell them what to do. All right? So they got to be careful with coiling cords, right? And certainly, use the holsters. I just did this lecture at one hospital and we were going around. I come back, I look, we were doing some OR evacuations, and this guy was in the room. And I look in there, and I'm like, what the heck? He's sitting at the head. They were doing some sort of crane, and he's throwing the unit right up on the guy's shoulder. And he's cutting a little more, throws it back up there. I'm like, put a holster there. That's how, that's really where you can get into trouble. But anyway, keeping the electrode clean, which is important. They definitely, with fiber optic, it's really visual checks for light bundles, inspect insulation, checking the connections. Those are all things we should be looking at for the light source safety. Laser is really, I can tell you the Joint Commission has been hot over the last year of having having goggles right outside the room and having proper signage there. They're hitting people left and right with that, so just be cautious with that. If you don't have it and your window's open, I would certainly consider getting it. And then, so the next piece, if my clicker would work, there we go. All right, during an evacuation, what's their main role? So certainly it's stabilizing the patient. It is going to be, they need to, and it was probably 10 years ago that we changed our procedures to say we give the surgeon the last word to move. And what happened is there was a couple cases that year, and then one the previous year, where they had a huge volume loss by the time they moved from the OR and went to another OR, their evacuation site from the OR to PACU. A lot of times that's where ORs evacuate to from a fire. So when that happened, we've changed the procedures to say the surgeons have the last word to move the patient. And the reason is they, in all these cases are like, listen, if I had 5 or 10 more seconds, I could have nicked a couple of these bleeders and we wouldn't have that huge volume loss. It made sense. Talked with the folks when we help us make these procedures with the medical staff, and they all were in agreement with that. So we want to certainly close, or depending upon where you are, at best cover the site, communicate when we're ready to move, and then they set the pace of the evacuation. So what do I mean by that? It means you guys telling them, all right, you get ready to close up, cover whatever you need to do, and then make that path, right? Clear it all, and then go. And they pretty much usually don't do anything and follow behind and try to keep things sterile. But they really, we have all the other people on the table moving, and then people grabbing that equipment. And it really is going to be. When we get into a lot of my smaller community hospitals, they have that fire in the OR. It's like, all right, now what? I'm in PACU. When's the last time you guys finished a case in PACU? Never. But that is where they got to figure out about what they're transferring, what are they doing. So we talk about evacuations a lot through this, right? So here's the good news. It's not good news, but the good news is if the fire is in or on the patient, you're not moving, right? You're just not. You can put that fire out, but again, if it's in that OR with equipment, we've seen that of recent, and you really now your whole OR is filling up with smoke, and you're going to need to get out of there. So again, the surgical team rules, it's really going to be packing up, getting everybody ready, and moving out of there. So the other piece to this is that before we dive into fire suppression, this is going to be chaotic. It's going to be, very difficult at times, depending on that case of moving out of there. I can't stress enough, this is all about communication. And really and it needs to be the leadership team getting into that OR, figuring out what's going on, where they're going to evacuate to, and set that up and get them ready or prep that other OR for where you're moving. It is just critical. When we talk about different types of fire extinguishers, you have the ones in the hallways right out here, and those extinguishers are ABC. It's a powder. Has anybody ever seen one of those go off? All this yellow dust everywhere, right? Do you want that in your OR? Absolutely not, right? So those are, you can use for everything in here. They're every 75 feet from no matter where you stand in this building, because that's code. So you have it. They are the ones that, do you guys have the red ones or the white and blue ones in your ORs? Red? All right, so that red is a CO2. Those extinguishers are probably the most common. You can use them on anything in your OR, if it's equipment, anything else. Do you really want to use it on a patient? Not really, but we've certainly for drape flyers you can use them for anything like that. Again, on the patient, we want to use a towel, saline, any of that. These extinguishers, the biggest thing about the ones in your OR, you see that aluminum tube that comes out before the black handle? When you grab that extinguisher, you're going to grab hold of that black handle and you're going to pick it up and you're going to aim toward whatever's on fire. Hold the bottom of the extinguisher, then squeeze. I don't want your hand anywhere near that aluminum tube because you can end up actually with a freeze burn. It's so cold coming out of it. What you get you'll see it's very loud. It blows this thing out and you will see some pieces of like white chunks of stuff coming out at you. And that's just the gas that's in there. All right, and that's again why we don't want to go and we don't want that on a patient. So again, you can have everyone in there. The biggest thing I see a lot is these things are blocked, so when you need them, you got to push stuff out of the way to get access to them. So in the OR, you're using the one in the middle. Everywhere else in the hospital has the one with the X on it, and that's because we don't want that in your OR. All right. So let me actually blow this up just a little bit so you guys can see it a little better. So this is your floor plan. We've got, what you're looking at there are your fire rated walls and then your doors. So when we look just up to the top and of your ORs, 15, 14, 12, and then what you got here is an arrow where it's pointing. So it's right here. Where this is going through one of your doors, okay? Let me explain to you how this works. You've got those walls that go outside. So if you look at OR 10, outside wall comes up and over, up by 18, goes all the way across. This thing goes forever, right? This wall starts here, goes up and over, comes down this way, and then continues up all the way up and over. What this does, folks, is it makes compartments. It allows you to go through those doors. So those doors are 45 minutes in that hallway. When they close, they become part of that wall. And again, outside wall to outside wall. Floor up through the ceiling, and it ties into the deck above. So you could have a fire in say OR 14, and it's filling that whole area up with smoke. On the other side of those doors, you're perfectly safe. It's holding all that smoke back. 45-minute rated for fire. For smoke, keep them closed, and it keeps smoke out of there forever. Are you ever going to have a big fire here?
Hopefully.
What do we have here? Yeah, you got it, sprinklers. So if you look above your head, you see these little white discs, right? This building is 100% sprinkled. That's the good news. You want to know the bad news? You are 100% sprinkled. What do I mean by that? So here's how they work. As each one activates by heat. So each one needs to hit 155 degrees. As it hits that 155, it starts spitting out water in an 8-foot pattern at 20 gallons a minute, and it is the nastiest, stinky, moldy, disgusting water you can imagine coming out at you. You can't turn them off until the fire department gets here. So if we had a fire in OR 14, how long before the fire department gets here and is standing in front of OR 14 to say the fire's out? What do you think? 15 minutes. I'll buy that. So if you had one going off, every 10 minutes it produces 200 gallons of water. So 15 minutes, we're at 600 gallons of water. Where do you think all that water's going? You got it. It's blowing out everywhere and then down. So let me ask you this. Do we have a floor above us here? I didn't even look when I came in. You're on the top floor?
Yeah.
All right, that's good. Why is that? Because if there was a fire, let's just say you had a third floor up there and there's a fire, where do you think that water's coming? Down to you. This is what forces buildings, specifically healthcare, to have to evacuate and pull out of there and get out of that area is because not the fire, not the smoke, it's the water. It causes thousands and thousands of dollars worth of damage. There was just a fire in a nursing home that you had here that a 70-year-old woman actually lit this fire in a nursing home. And it was about $150,000 worth of damage to that room, one sprinkler. They actually arrested her on arson. So it's all about this water here. So what I need you to be able to do is if you do have this fire and this thing starts spitting out all this water, you're gonna need to get out of that room pretty quick. And you hope that the sprinkler is not going off near your exit door, because you're gonna get awful wet. So these are the things I need you to know of where, first off, your suppression between your, extinguishers and all that, but these sprinklers, they do a great job, but I've been doing this a long time, and anybody that's been through a fire, what I always hear is, I can't believe how much smoke, and my God, the amount of water. And that's what you hear. So, all right. As far as these floor plans, this is, again, all your fire doors, and why is this so important? Because if you've got a case going on, you can't take that patient and bring them down a flight of stairs, right? No. This is the way all healthcare is designed. Any fire, you go horizontal through those doors. We never go vertical, and we never go outside. I've had ERs. There was a hospital in New York City last summer. It was hot like it is now. AC unit on the roof caught on fire. Well, those roofs are rubber. So when that caught on fire, it was a huge black head wall of smoke. I mean, it was monstrous, and nobody in the hospital could see it, right? But everybody running inside to the ER, your hospital's on fire. It's a huge, get out of here. So the whole ER of 130 people that were in that ER at the time are all standing out in the park. The fire was 18 stories up. They don't got a problem, but that is what people think is they need to get out, and I hear it all the time, especially in the first floor. But you guys are not in that case where your patients, you're just not stable enough to move. And the last thing you want to do is go out. There was a case in Massachusetts, Brockton Hospital, 4 years ago now. They had a fire at 7:20 in the morning. Their main electrical panel caught on fire, and their generator, so they had to turn that off. Then, of course, what comes on? The generator. They had to shut that down. Every piece of wire in that hospital was replaced. But when that fire happened at 7:20, they just started 2 cases they had going on, and they were in a complete darkness.
Oh.
I mean, pitch black, nothing there, lights they had lights on, flashlights, all that to try to stabilize it. But think about it, we lose power, and you have no windows around here, right? So it is, they had 160 patients in that hospital. They had them all cleared out of there within about 6.5, 7 hours. But those cases going in the OR, that was an event. And it was interesting talking to them. Right before they opened, I went up and did their OR program. And it was interesting talking to them because, they lost all the anesthesia, everything. So they're bagging, all your pumps, nothing. So again, horizontal evacuation, that's to keep you safe. All right, where are you evacuating to? Patients from OR 1 through 11 and HCVOR 18-19, they're gonna be moved to PACU phase 1. If we need to update this, if this doesn't make sense to you, let me know. Because I know you guys have had your new OR, and hopefully who was here last updated this, but patients from 12 through 15 and hybrid OR 17 are moved to OR 1 to 11. Why are we doing all this movement? Because what are you going through?
Firewall.
Firewalls, right? Fire doors, exactly. C-section, where they're going GI, and then your pre-op and PACU are moving through, that's where they're going as well. And again, it's all to get you through a fire door, firewall, and horizontal and keep you safe. All right. Cath lab to the ED and interventional radiology.
They're downstairs. So.
Yep. You've heard me talk about doors and why closing doors are so important. What you're looking at here is I was a director of an ambulance service 23 years ago in Hartford, Connecticut. We had a nursing home fire where 14 people died, 38 transported out. What you're looking at there, now they had no sprinklers in there, but the picture on the left represents where that fire went and roared down that hall. Okay? What the picture to the right is the other side of those doors. can't even, if you were looking down the picture on the right, you wouldn't know there was even a fire that took place, but that's what happened. I can't tell you and stress enough, shut doors. You shut doors, lives are saved in any of these fires. All right, last one coming out of there. Again, we talked about this with the medical gases. I'll go through that with you when we get in there, but it's really just the main thing is if you're gonna shut one, shut them all down, and pretty easy to do. And lastly, fire department. So, as I said earlier, the fire department's really not a big fan of coming to your own. But this is where it's really key on communication. When they get there, it should be coming to your control desk, right? I need leadership, somebody there to meet them to say, hey, we had a fire, it was a Drake fire, it was this, it's out, it's done, we're continuing with the case. Whoever's in charge when they got there from the fire department may want to put a bunny suit on and go there and like peek in the door, make sure everything is good. Truthfully, if they know the fire's out and you're continuing with the case, they're going to call the fire marshal. Fire marshal's going to get there. He or she is definitely going to want to put a bunny suit on and get in there and see what's what. And they're also going to want to talk to you guys. What happened. This is how and why it's so important. When you look at equipment malfunctions, you could have an equipment failure and don't realize that this happened 100 other places. And the fire marshals, when they do this investigation, they have this huge database with all equipment failures on any industry. And this is where you can see a trend. And you're like, oh, this is the 6th time we've had this unit have a failure and cause a fire in an OR in 2024, 2025. It's the only way we can figure that out. So make sure they're briefed, give them the update status of the fire. And then to be quite honest with you, only thing he or she from the fire department is going to be concerned about are any life safety issues. Is the fire still going and are people safe and we don't have to go do any rescues? If they know the fire is out and the case is going, they're good. But if they're not met and they don't know what's going on, they're barging into your own wherever the heck this fire is. And they're not going to be putting buddy suits on. I can tell you that right now. So again, just a key thing that just some things to know about it. All right, as we finish up, how should flammable material like alcohol-based antiseptic be handled and applied to reduce the risk of ignition during surgery? What do you think? Right? Yeah, right? Appropriate dry time. Please, please, please document that dry time. It's so important if you have something that does happen. Any fire in or around a patient in the OR, it requires immediate evacuation. Oh, absolutely. All right. Know your fire procedures. What's RACE stand for? Rescue, alarm, confinement, and then evacuation. Some places say extinguish too. Where are your pull stations? If we have to pull a fire alarm, where are they? Come on, you look at them every day. Near the stairwells, you're right. All right, do you have one at your nurse's station at the desk, the control desk?
I don't think so.
No? Okay. So listen, I don't care if you're here working, out to dinner, grocery shopping, wherever there is a fire alarm system, you are always, always, always going to find them at an exit. That's code. In theory, what are we doing? We're running out of the building and you're pulling your alarm. We're healthcare, we can't do that. But your building is designed to keep you safe. But know where that alarm is, and that's definitely important. All right. What are the first steps to take if a fire starts in or on or near a patient during surgery? Come on, Ian. What I say to you guys? Well, fire, shut off the gases, right? That's right, the key thing. All right. Questions for me? Does this make sense?
It does.
Good. So I hope the biggest takeaways for you guys today is your prep solutions, your dry times, looking at your high oxygen rich environments, your prep solutions, and then knowing where how to activate your procedures. And then really, guys, this is all about communications. It really, really is. You have a fire, they're ugly, they just continue down the road, and they're very expensive. I'm actually have a meeting with a woman next week, actually, who is from one of the big insurance companies who insure a lot of healthcare facilities. Because there's no way for us to really figure out how many OR fires there are a year. But what I asked her to give me is, tell me from 10 years ago, how many cases you had, and what the money, what dollar value was, so what was paid out, and then tell me the last 2 years. So I want to be able to see, are we seeing a trend down? And what are we doing for, I mean, it's the only way we can truly figure out. So there's really 3 companies out there that are really the big insurance providers on this. So hopefully we can kind of figure out what's what. That's all I have then. If you guys could just use this QR code, take a quick hit of it, open it up. There's a 10-question survey in there. It just helps us what you thought of the program, and more importantly, you know, what do you want to see for you know, next year. We're always looking for newer material, but again, sometimes that can be a little hard to get. But you know, we're in the business. We hear a lot what's going on, and we want to be able to bring that back to you guys. All right. Any last questions? Good. All right. Have a good day.
Thank you.
You are welcome.